Hello everyone, and thank you for joining us for the July Model Aquatic Health Code Network webinar entitled Update on the 2016 MAHC and Local Aquatic Inspection Data as Surveillance Data. My name is Kelsey Edge, and I'm a program analyst at the National Association of County and City Health Officials, otherwise known as NACCHO. I've been helping to support this initiative. I'll also be your moderator today for this webinar. Before we begin, there are just a couple of announcements. Please mute your computer speaker if you're using a computer to prevent any audio feedback. If you've not done so already, please call into the webinar conference line for the audio portion. You can do this by dialing into the conference line that's projected on the screen. Also, due to the number of high amount of attendees on this call, all participants will be muted via phone, so please submit all comments and questions via the chat box on the right side of your screen. Also, the recording of this webinar, as well as a PDF version of the slides, will be made available on the NACCHO MAHC Network webpage, so be sure to check that out. So again, welcome and thank you for joining. Kicking us off today will be Jasen Kunz with updates on the 2016 MAHC, and then we'll turn it over to Michele Hlavsa, who will give a presentation on local aquatics inspection data as well as surveillance data, whenever you're ready, Jasen.
Hi, this is Commander Jasen Kunz from the Centers for Disease Control and Prevention. Specifically, I help co-lead the Model Aquatic Health Code program here at CDC, and I'm also a board member on the Council for the Model Aquatic Health Code. Doug Sackett, the Executive Director for the Council for the Model Aquatic Health Code, was unable to join today, and I have a couple quick comments on his behalf. Please excuse the skewed slides. It has to do with how PowerPoint gets translated into this medium. So I wanted to first start off, provide some background information on how the Model Aquatic Health Code will be kept up to date, and we'll ultimately conclude with speaking about the second edition of the Model Aquatic Health Code that is to be released in the coming days. So CDC owns and revises and publicly posts the document. So it's still a CDC branded document as it goes through the CDC clearance process here. And upon creation of the Model Aquatic Health Code, there was a need to renew and update the MAHC. We recognize that industry trends and science changes rapidly in this arena, and therefore a sustainable update mechanism is needed to ensure that the code is updated and useful for all of our stakeholders. And it needs to be a self-sustaining mechanism, and it should include public health, aquatics, academia, and general public. I think that was one of the hallmarks of the creation of the Model Aquatic Health Code to begin with, was that inclusion of all stakeholders in aquatics health and safety. And this conduit should gather national input and decide on scientific merit and summarize changes needed for CDC to accept. In benchmarking, we looked at the Conference for Food Protection, which oversees the update for the FDA Model Food Code. So the Conference for Food Protection is a nonprofit organization that supports the FDA in collecting, assessing, and relaying code changes back to the FDA for acceptance. In 2014, the Council for the Model Aquatic Health Code, CMAC as we call it, was created. It's also a 501c nonprofit organization modeled around, as we described, the Conference for Food Protection, and it has a bylaws board of directors, an executive director, Doug Sackett as I mentioned, and it also includes multiple committees, which at the top would be the Technical Review Committee, and various ad hoc committees, whether they are research committees or even technical committees. And a couple of the research committees we have right now, one going on is around cyanuric acid, the other one is chlorinator sizing, and we recently launched an acoustic ad hoc committee to look at sound levels and ways to control for them in aquatic venues. So the role of the CMAC is funneling advice and data-driven science-based information for public health and aquatics experts at CDC. They are the workhorse that takes change requests, puts them through the conference voting process, and sends them back to CDC for consideration and final acceptance. And they also provide needed support to health departments and other partners using the MAHC. We see the Council for the Model Aquatic Health Code as very much kind of as that force multiplier to help CDC and other to reach out to the health departments and provide support, whether it's questions about adoption or even questions around code interpretation or explanation that is needed for a particular code item. And also, they're critical in soliciting, coordinating, and prioritizing our research needs, as we described earlier. So we hosted our first Vote on the Code conference in 2015. This was in October, where we considered 159 proposed revisions. So these were change requests that were submitted to update and change the Model Aquatic Health Code. We had 120 in-person attendees and around 100 people live streaming. And the way the process works moving forward and currently is you have the change request, you have the input, it translates into a change request, that gets submitted to the Council for the Model Aquatic Health Code. Anybody can submit a change request, and the technical review and discussion occurs internally with the Technical Review Committee, and they look at it for scientific merit, they look at the research associated with it, and and they also kind of apply the lens of, is it evolution versus revolution? And we have conference presentations on these change requests that are put up by the Technical Review Committee, and ultimately the Technical Review Committee, after looking at all of those parameters, recommends to membership whether it should be accepted or rejected. And it's up to membership then to ultimately vote on those change requests. So the Technical Review Committee plays an important role in providing details to membership for voting consideration. After the votes are tallied, it is collated through the Board of Directors and then relayed to CDC for final consideration and acceptance. So with the current, in 2015, we had 92 revisions of the 159 that were approved by membership. And what we found out is that the online voting system worked. So the voting occurs 2 weeks after the conference is completed. And results relayed to CDC in January. And what we're finding here at CDC is that this is the first time that we've utilized this process. And we anticipated early on that we would release the MAHC second edition at the end of May, but we're finding that our clearance process here takes just a little bit longer than we envisioned. And the MAHC will be released here very shortly, which I'll get to in a moment. So what were some other lessons learned through this first process through? We're realizing that we needed more time to review the change request, that we needed additional technical support for the Technical Review Committee. So one of the things that we're going to do recommending forward is reconstitution of the technical committees. So for example, a change request comes in that is heavy on ventilation. We have ventilation experts out there, other CMAC members, that can be called upon to provide additional expertise for the TRC to consider and weigh in on that change request. And also, one of the things that we're moving forward with on is listening sessions in the interim years. So right now we're in an off year for the conference cycle, and we hosted our first listening session at the National Association for Environmental Health Conference in San Antonio in June. And we plan on hosting a couple more this year, one of them at the World Aquatic Health Conference. And this is where we will spend a few hours with membership to talk about the research needs and future directions of the MAHC and allow membership and attendees to weigh in on that direction of the MAHC. So the MAHC second edition. I had hoped we would be able to talk about some of the details of it today. I will say that it is scheduled to be released the week of July 18th. It is right now with our web team, so it is in the absolute final stages of getting put up on the web and released. So we anticipate it going out on Monday, July 18th as the release date. So there will also be a track changes version as well as a clean version being released. So the track changes version is intended for people to go through who want to see where the actual changes are that occurred in the MAC and go through that quickly. We'll also have a summary of key changes posted, more of the higher level type changes for those of you who want to see the major changes into the MAC. And we're also, a summary letter was being posted, and this is really a transparency rationale for not accepting certain change requests. As we indicated earlier, the change requests are submitted, the voting results are submitted to CDC for final acceptance, and CDC carefully looks at all of those voting results and applies our scientific clearance process to those voting results. And at this point in time, I can say that all but only a few were not accepted by CDC. And as part of this letter that comes out, it will have the clear rationale for why they were not accepted. And we also have an updated website and infographic for educating stakeholders. So spend a few minutes on the website as well next week once the MAC is released. And I'll conclude with, as Doug always indicates, get involved with the Council for the Model Aquatic Health Code. Really, the MAC is only as good as your expertise. And mark your calendars for the next Vote on the Code conference, which is October 17th and 18th, 2017. And the code, the third edition of the code cycle will be starting shortly. Thank you. And we'll have questions later at the end of the webinar.
All right, thank you so much, Jason. All right, next we're going to hand it off to Michele Hlavsa. Are you there, Michele?
Yes, I'm here.
All right, feel free to take over whenever you're ready.
Okay, thank you. So before I get too far into my part of the presentation today, I do want to acknowledge all the colleagues who made this project possible. So our colleagues in Arizona, California, Florida, New York, and Texas, as well as at CDC. I'm the one presenting the data. However, what you see here in this presentation is a result of the work of a lot of people. Okay, so basically in my presentation, I'm going to cover, I'm going to provide a background, giving you an overview of swimming and talk about national surveillance for recreational water-associated illness and injury, talk about the methods of the work we did and the results we found, and in the discussion, talk about implications of what we found, examine the limitations of the data we're looking at, and share conclusions. In terms of background, as many of you know, swimming is a very popular sport. It's estimated, according to National Sporting Goods Association, to be the fourth most popular sports activity. Back in 2009, they estimated that over 50 million people go swimming in the U.S. each year, and these are people ages 7 years or older, swimming at least 6 times a year. This translates to over 300 million swimming instances annually. We at CDC feel that this is an underestimate because, as you know, if you go to a pool during the week or even on a weekend, who's at the pool? It's the ones that are 6 years and under. According to PK data, there are over 300,000 U.S. public aquatic venues. And when I talk about public aquatic venues, I'm talking about pools, hot tub spas, and water playgrounds. And when I'm referring to public, as many of you know, I'm referring to anything intended for more than one household to use, just in general broad definition. This could be at a water park, hotel, motel, apartment complex, pool, etc. One thing about, swimming and other forms of physical activity in the water is that there are a lot of health benefits, as with any form of physical activity. As many of you know, we're currently fighting an obesity epidemic. It recently came out that 40% of American women are obese. Here's a form of physical activity, get at that. And, this form of physical activity might be the only option for a lot of the U.S. public. There are people with medical restrictions. We have an aging population. These are people who are unlikely to get up off the couch and go train for a marathon. But, going to the pool, doing water aerobics could be an option. And the nice thing is that this water-based physical activity can improve physical and mental health across the lifespan. This could be with little kids. This could be with an option for the elderly as well, as I mentioned. So it's about managing chronic illnesses. Studies have also shown alleviation of joint and muscle pain, maintaining bone health, reducing anxiety and depression, increasing social connections among family members, for example. So given this balance, given that we know there are these health benefits, we also have to acknowledge that there are some risks for illness and injury, as there are with any form of physical activity. So the real public health goal here is to balance maximizing the health benefits while minimizing the risk for illness and injury. And the way we do that is we collect data to figure out how we best do that. So we need to do surveillance to characterize the epidemiology. So we need to track what's going on across the country to see what's going on. And when I'm talking about characterizing epidemiology, I mean estimate the magnitude. How many cases of drowning are there each year? How many cases or how many outbreaks are there each year linked to swimming? Document the distribution. Where are illness and injury occurring? Are they occurring at the water park? Are they occurring, at hotel motel pools? And to track the natural history. Over time, do we see a change in the number of cases of injury or illness that we see in a given year? And basically, when we have these data, we're empowered to implement our prevention efforts, to optimize, our illness and injury prevention. These data can inform our efforts, help us target our efforts, and evaluate them. So what do we know in terms of national surveillance data right now? So one thing the CDC tracks is recreational water-associated outbreaks. So these are similar illness in 2 or more persons that are epidemiologically linked by location and time of exposure to recreational water. This histogram here shows the almost 900 outbreaks that have been reported to CDC since 1978. 1978 was the first year waterborne disease outbreaks were reported to CDC. This histogram goes to 2012, the last year for which we have finalized data. And you can see, especially since the late 1990s, there's definitely been an increase in the number of outbreaks reported to the U.S. You see orange bars and blue bars. The orange bars represent the outbreaks associated with untreated wreck water, so our lakes and our oceans. And those have been pretty stable over time. What hasn't been stable, what has been increasing over time and driving the overall increase has been outbreaks associated with the aquatic venues, for example, like our pools. And again, here, just looking at the blue bars, you can see that increase, especially after the late 1990s. This histogram here focuses on the aquatic facility-associated outbreaks by year of occurrence to CDC, and it breaks it down to type of outbreak. The blue bars represent aquatic facility outbreaks of cryptosporidiosis. The orange bars represent outbreaks associated with spas and being caused by Pseudomonas, so Pseudomonas folliculitis, and the orange bars represent all other outbreaks. And as you can see from the graph, it's really the cryptosporidiosis outbreaks, the blue bars, that are driving the overall shape, especially in the last decade or so. You see a little bit in the early 80s, the orange bars standing up and really driving the shape of the histogram, and that's because in the 80s, early 80s, as most of you know, hot tubs and spas really made an appearance in our homes, in our hotels, motels, and we didn't have standards on how to maintain and operate them. And it took a while to develop those and for the number of outbreaks to go down to some extent. In terms of drowning, our national surveillance data tell us that there's approximately 4,000 annual deaths due to drowning, and that it is the leading cause of injury death among children ages 1 to 4 years. And among this age group, over half the drownings occur in a pool. In terms of non-fatal drownings, there are approximately 5,800 annual visits to emergency departments across the U.S. More than half of the patients are ages 1 to 4 years. About 2/3 of drowning among children in this age group occur in a pool. In terms of pool chemical-associated health events, they're anywhere from 3,000 to 5,000 annual U.S. emergency department visits. About half the patients are less than 18 years of age. When we start looking at the reports, we find that patients are injured when they're handling chemicals without proper protective equipment, such as goggles or a mask or a respirator, and not securing chemicals away from children, which means that children get into them, and mixing incompatible chemicals. So as many of you know, pool chemical labels actually list what chemicals are incompatible with the chemical you're actually using. Unfortunately, label reading is probably not done as often as it should be, and we often mix chlorine and acid and generate toxic chlorine gas. So all of these reasons for these pool chemical-associated health injuries are very preventable, as you can see. So in terms of prevention, as Jason talked about the Model Aquatic Health Code, the MAHC, I don't want to get into too much, but just to give you some idea of a timeline, back in 2005, the Council of State and Territorial Epidemiologists, or CSTE, called on CDC to develop a model code. From 2007 to 2014, CDC and the New York State Department of Health spearheaded a multi-stakeholder effort to develop this code. As Jason mentioned, this was bringing in academia, this bringing in the public, this was bringing in representatives from the aquatics industry. This wasn't a public health only effort. And back in August 2014, the first edition of the MAHC was released. And it's intended as a public health resource to optimize the prevention of illness and injury at our public aquatic facilities. So now that we've developed the MAHC, and we know here at CDC one of our strategic priorities is to prevent illness, injury, disability, and death, it kind of becomes a big issue of, you know, what do we need to do? Well, we need to assess now the MAHC's impact on public health, but our surveillance systems probably won't help us do that, at least not the way they're set up to right now, and especially if we're going to focus on the design and the construction standards within the MAHC in terms of assessing their public health implications. We don't see the number of outbreaks suddenly dropping. It's going to take a while for our state and local partners to consider the MAHC, to possibly, you know, adopt parts of the MAHC, and for that to take effect over time. So, you know, given that we can't use the surveillance systems that we have to assess the MAHC for years and decades, we try to come up with an interim solution, and that was setting up another surveillance system based on inspection data and using those as a real-time assessment of the operation and maintenance of our public aquatic venues, thinking of the idea of the outcome being the violation or the closure. Usually when you do surveillance, you're tracking an outcome like illness or injury. This time, we're tracking closures and violations. All right, so what did we do? So we decided to set up the National Aquatic Facility Inspection Surveillance Network, or NAFIS, in collaboration with our state and local partners across the U.S. And we focused on the number of public aquatic venues, routine inspections done in each jurisdiction, the percentage of inspections resulting in immediate closure or that identified one or more violations, and we tried to drill down into the data a bit more, specifically focusing on 15 critical risk reduction MAHC elements: the aquatic facility-associated illnesses, the outbreaks, you know, the drowning, the pool chemical-associated health events. What these 15 MAHC elements were really key to preventing these illnesses and injuries. And overall, we tried to look at the data by venue type, by pool versus hot tub or spa, and by pool category, wading pool, interactive water play venue, for example. And this map here highlights the 5 states that we worked with: Arizona, California, Florida, New York, and Texas. And what we did is we focused on these 5 states because they have the most public aquatic facilities, and then, or aquatic venues, excuse me, and then we looked at their top 5 local jurisdictions in terms of number of public aquatic facilities. In Arizona, California, Florida, and New York, those were counties. In Texas, it was a specific city. And this is basically, this flow chart here covers what we did in terms of NAFIS, in terms of, you know, how do we decide what data we were going to look at and analyze the data, et cetera. So first we determined what inspection items to look at. Once a local partner agreed to work with us, or a state partner agreed to work with us, we asked them for their pool code, their pool inspection form. We went through it, and we said, okay, based on these 15 items in the MAHC, what best matches to that? What happened was that we then went back to our partner and said, does this look like we made the right, you know, judgment calls? And sometimes there was some back and forth to determine yes or no that we didn't. Once our partner signed off on it, we considered the list finalized, and then we requested data. And we have a phenomenal biostatistician here who was able to reformat and standardize the data, analyze the data, and then we reported the findings back to the jurisdiction. And we didn't consider the findings for each jurisdiction finalized until the jurisdiction signed off. And then what we did is we took all the data sets that were signed off on, or all the data that were signed off on, and put it into one database and analyzed that. And those are the findings I'm going to report on now. So in terms of results, the 16 jurisdictions that participated, 9 were unable to participate in this round, either because they didn't have electronic data back in 2013, or they weren't able to pull all their data or even access their data. So we worked with 16 of 25 jurisdictions, and these 16 jurisdictions did 84,187 routine inspections of 48,632 venues. Over 12%, or almost 1 in 8, public pool or hot tub spa inspections resulted in immediate closure in these jurisdictions, and over 3/4, or 78.9% of inspections identified one or more violations. The median number of violations was 2, with a range of 0 to 21, so that means some inspections found as little as no violations. Others identified 21. So in terms of preventing aquatic facility-associated illness, the 5 items we focused on were whether or not the disinfectant concentration for chlorine or bromine was where it needed to be, whether the pH was where it needed to be, and whether the recirculation pump and the filter and the automated chemical feeder were in good repair, operable, operating, whatever the case may be. The numbers I want to focus on is, among these routine inspections, almost 12% identified a disinfectant concentration violation. Unfortunately, I can't tell you if those violations were too high or too low. Those data were not shared with us. Proper pH, again, 14.9% of inspections identified a pH violation. Again, we're unable to tell if the pH was too high or too low on inspection. And automated chemical feeder being in good repair, operable in terms of violations of that, 5.2% of inspections identified a violation. In terms of preventing drowning and entrapment, the 5 items we focused on were fencing, walls, or basically enclosures, gates and doors, being in good repair, and self-closing and self-latching, or that's specifically the gates or doors, whether the water was clear and the main drain was visible, whether the main drain covers were compliant with VGB or with ASME ANSI standards, and whether they were in place and in good repair. Qualified or adequately staffed lifeguards, and we also looked at safety equipment like a hook or ring. Was it in good repair? Was the first aid kit present? The numbers I want to focus among these items were the enclosures. Over 5% of inspections identified an enclosure violation, and over 12%, or more than 1 in 8 inspections, identified a safety equipment violation. In terms of preventing pool chemical-associated health events and other non-drowning, non-entrapment injuries, we focused on whether chemicals were labeled and stored safely and whether they were secured, whether hot tub and spa temperatures were maintained at 104 degrees Fahrenheit or 4 degrees Celsius or less, and whether the protected overhead electrical wires or the GFCI or the ground fault circuit interrupters electrical outlets were present. And among these numbers, I want to highlight the hot tub spa temperature. So about 7.5% of routine inspections identified a water temperature violation. And finally, the last 2 items that we looked at apply to general health and safety. Was there a qualified operator or responsible supervisor on site? Were there substantial alterations or equipment replacement violations, meaning they weren't improved? And 1% or less of inspections identified violations on these 2 issues. In terms of routine inspections, if we look by venue type, meaning pool versus hot tub spa, we see that most of the inspections from the 16 jurisdictions that we worked with this time around, almost 2/3 of the inspections were of pools, almost 1/4 were of hot tub spas, and the remaining about 10% were unknown. When we break down the inspection findings by key venue-specific findings, we find that a lot of the issues that we're seeing are with hot tub spa inspections. So 15.1% of hot tub spa inspections resulted in immediate closure. And if you remember, overall, it was 12.3%. So it's really the hot tub spas that are the issue. 19.2 identified disinfectant violations. and I believe overall it was 11.9%. So clearly disinfection violations are an issue for hot tub spas. 27.5% identified pH violations. Again, pH violations in hot tub spas are affecting the inspection results overall, and 7.5% of hot tub spa inspections identified water temperature violations. When we look at the data in terms of pool category, so are we talking interactive water play venue, wading pool, what are we talking about? We found that most of the jurisdictions we worked with classified a pool as a pool. They didn't specify the pool type. So over 95% of the inspection records we looked at were specific to a pool, about 3% to a wading pool, 0.1% to an interactive water play venue, 1.3% to other. If we break that down to key pool category-specific findings, the troubled pool category would be the kiddie wading pool, the inspections of those venues. So 21.6% of routine inspections of kiddie wading pools resulted in immediate closure. 19.2% identified disinfectant violations, and 26.0% identified pH violations. Now, this is especially concerning when we think about who's going into these pools. It's the little guys, the ones 5 years or less. The ones that have tend to be sick with enteric diseases, tend to not have good hygiene skills, not good toileting skills, so they're probably introducing a lot more urine and a lot more fecal material into the water, and then they're also probably drinking the water more than adults would be. So this means that they're not only contaminating the water, they're drinking the water, so it becomes really concerning when we see that, the disinfectant and the pH violations. In terms of aquatic venue type by setting, whether we're looking at pools or hot tub spas, we're in a bit of a lurch here. Most of the jurisdictions we're working with do not collect setting data. So over 99% of the records, whether it's pool or hot tub spa, didn't have setting data with the records. So we honestly, at this point, can't tell you whether these pools with these closures or with disinfectant violations were at the hotel motel, were at a water park, etc. So in terms of discussion, so the take-home message for all stakeholders, I think this report, the definite goal here was not to discourage anyone from swimming, but actually, to call all the stakeholders, call on all of them to do better. We can do better. Patrons and aquatic staff should not be getting sick or hurt at public aquatic facilities. We're never going to, totally prevent it, short of shutting down all public aquatic facilities. We're never going to totally prevent this from happening. But it is about minimizing the risk of illness and injury. And, going back to what we were trying to do here, assess the impact of the MAHC, the MAHC is about getting a minimum set of standards across the U.S. and increasing them over time. And as Jason said, this is evolution, not revolution, and making it harder for the bad apples to stay in the game. Making sure that bar gets raised to the point where, the ones who can't keep up, fall out of the game. So take-home message 1, environmental health practitioners play a vital role in preventing aquatic facility-associated illness and injury. Clearly, if we're closing 1 in 8 pools on routine inspections, it really highlights the role that EH plays in protecting public health right there on the front line. Unfortunately, only 68% of U.S. local public health agencies regulate, inspect, or license public aquatic venues. I think this was it was a big surprise for the public. One, I think a lot of the public doesn't know that our public aquatic facilities are inspected, and another push that we made during Healthy and Safe Swimming Week was to raise awareness that this is being done, because I think there's a greater awareness of inspections that are done of our public food establishments. But I think secondly, the big role is, wow, if these inspections are being done, why aren't they being done in my community? So what are the implications of public health in terms of all of this? Inspection is basically an opportunity to educate the operators about how and why to properly operate and maintain venues. This isn't about penalizing the pool operator in terms of, just for the sake of penalizing them. This is about educating them to make sure that the same violation doesn't occur, time after time. And as we said earlier, violations represent a risk for illness and injury. So that risk gets minimized, that, over time there's less and less risk of illness and injury. I think there's possibly, a role for inspector training. One thing that we're going to look at in the future through these data is, is there variation between inspectors? How can we make inspections more effective? Increasing awareness of and access to inspection results. We strongly encourage the public during Healthy and Safe Swimming Week to access the inspection results, to go to local health department websites, to start asking, the pool operator about, what was your latest inspection score? To increase the public's awareness, posting these scores prominently at the venue and online. And again, going back to food establishments, when we go into the lobby of a restaurant, we see the inspection score there. Or when we go to the drive-by window, the inspection score is posted at the window. So, we should be doing the same at our pools. And one thing that we kind of like to see over time, and I think most jurisdictions do this, is to provide the inspection score or grade so that the public doesn't have to read the fine print to figure out what exactly was identified, but to make that overall judgment: is this place a place where I want to swim based on the latest inspection score? In terms of implications for aquatics, inspections are an opportunity to learn about how and why to properly operate and maintain venues. It highlights the need for operator training. On routine inspections, some of these routine inspections are announced. We should be closing 1 in 8. We shouldn't be closing on 1 in 8 routine inspections. And it's also looking at the 15 critical risk reduction MAHC elements. If CDC and our state and local partners are saying these are critical elements to public health and safety, do they match the operator's priorities? Do they match the aquatic staff's priorities? And again, using aquatics to increase awareness of and access to inspection results. It's not only about having bad scores and making someone look bad. This is also about, if you're doing a good job, if you got 100 on your inspection, posting that and letting the public know. Again, at the venue and even online and here, on the aquatic facilities website. I think it's much harder to turn around, once you've gotten somewhere and see an inspection score is bad and say, okay, to the kids, we're not going swimming today, versus, ahead of time going online and looking and making a decision right then and there whether or not to go swimming. In terms for the public has to take a more active role in keeping themselves and their loved ones healthy while at the pool and injury-free. That's a message that CDC has pushed for a while. This is not about, the operator taking care of everything and public health, following up and making sure that it's okay. It's about, the public, the bathers and parents of young bathers stepping up. This past year for Healthy and Safe Swimming Week, the week before Memorial Day, we really pushed the public to check their inspection results to see if they were available and what they were, to conduct their own abbreviated 4-step inspection using test strips to check the pH and the disinfectant concentration, using, looking for that drain at the bottom. Is the water clear, especially in the deep end? Looking to see if that drain cover appeared to be secured and in good repair, and looking to see if there is a lifeguard on duty, and if not, if there was safety equipment available. And talking to the public about, if they identify any issues on inspection, not to get into the water and notify the operator. And if the operator didn't fix this situation to their, satisfaction, going to the state or local public health department or public health agency to get this fixed. In terms of limitations of those results, the results might not be generalizable to the U.S. public aquatic venues nationwide. We worked with 16 jurisdictions, local jurisdictions. There are thousands of local jurisdictions in the U.S. However, these 16 jurisdictions have 15.7% of the estimated 309,000 U.S. public aquatic venues. Another limitation is that the number of venues and inspections of each venue vary across jurisdictions. So some jurisdictions are inspecting their venues more frequently. Some just have more venues, and some jurisdictions contributed more inspection records than others. It could be looked at as a limitation, but we also looked at it as a great opportunity. Some of our jurisdictions that were a bit on the smaller side gave us a view on what's going on with our smaller health departments and how we can help them, because they might have different needs than our larger health departments. And there was no overall standard in this jurisdiction, so every violation was basically a violation within its own jurisdiction. There was no overall, we didn't base this on the MAHC, we based it on what each jurisdiction decided, whether or not it was a violation. So, a venue that's closed in one jurisdiction might not be closed in another, and vice versa. A venue that isn't closed in one jurisdiction might have been closed in another based on their standards. So take-home message number 2, our IT and environmental health practitioners and epidemiologists can collaborate to unlock the full potential of pool and hot tub spa inspection data. Our environmental health practitioners bring to the table, the inspection experience, the knowledge on how to operate and maintain our public aquatic venues. EPI brings to the table, how to analyze data, how to do surveillance, and how to answer these questions about how many violations do I have, and where are these violations occurring, and I took this step to do prevention measures back in August. Did that mean that my violations for this specific inspection item dropped? The IT brings to the table, setting up a database, especially in a way that we can analyze the data and look at it and access it and extract it and use it to determine how we run our programs and how we do program planning and implementation and evaluation. So in conclusion, at the state and local level, these data can be used to determine magnitude of closures and violations to advocate for environmental health programs. I think having the public know that these are occurring, it's going to be a lot harder to shut down a pool program if the public comes to expect inspections of their program. And it's like somebody here at CDC once said, if you don't know it, you don't value it. So, really getting out there and sharing these numbers and making sure that, the boards of health and the public all know what our EH colleagues are doing. Characterizing the distribution of closures and violations by venue type is pool versus hot tub spa, by pool category, so interactive water play area versus wading pool, and setting, hotel motel versus, the water park. This is how, we're going to be able to plan, implement, and evaluate our pool inspection programs. And, and we're able to do this in an optimal way when we can target our enforcement efforts, risk-based inspections. If I know that I have, budget cuts coming down and I have only so many inspectors, where do I send my inspectors? Probably to the venues that have caused trouble, that have a history of closures versus, maybe, the water parks that has had a clean record for years. And where do my education efforts focus on? What standards in my community do I need to focus on to get the number of violations down because they have the most impact on public health? And inform and evaluate these prevention efforts. Looking at the data over time, are the number of violations, are the number of closures going down over time? At the national level, for us, this is an opportunity to share lessons learned with database vendors. A lot of the feedback we get from them is that everyone's needs are very different, and how can we standardize, and how do we make these data more user friendly and usable and useful to the public, and that's about optimizing the data collection and the storage to facilitate analysis interpretation. What do the data mean in the end? And that's really difficult if we can't access the data, we can't extract the data. And in terms of what it took here to get this report out, looking at, data from 16 jurisdictions. It took someone here 9 months full-time to reformat and standardize these data to the point where they could be analyzed. And I know our local and state partners don't have that kind of time to focus just on pool and hot tub spa inspection data. So what we did is, in the last bullet here, is a link to look at, some of the lessons learned when we went through, the data analysis. What can, lessons learned, like how should the database be set up so that the data can be extracted and interpreted, and how should the data be collected so it can be interpreted well. And another thing we were able to work on here at CDC, and this is, a joint effort between Jason and myself and some other colleagues here, was to come up with a model inspection form. And this is basically summarizes our lessons learned from these 23 route inspection data of pools and spas. And basically what we came up with is just basically just a snapshot of what's going on in terms of operation and maintenance. And this is just a baseline for the eventual evaluation of the MAHC. So here's my contact info. And I'm required, as Jason is, to have a disclaimer in my talk. And I'm happy to take any questions, or if there are questions for Jason.
Michele?
Yes?
Thank you for that presentation. So we have a couple questions in queue already. Others online, feel free to start asking your questions, and we will reserve the last 15 minutes here to answer any and all questions that you have. Michele, in your chat box, Susie Campbell wrote, what is the source of these reports? State EPIs only, that came early on. And then Mary Clifton asked, did any of the participating programs regulate private swimming pools? I know you looked at public, but you can read for yourself.
Okay. So, Susie, let's see, what was the source of these reports? So we basically worked with the 16 jurisdictions, 5 counties in Florida, 5 counties in New York. Those data came from the state because they have statewide statewide pool codes. So we got their data for their respective top 5 counties. In terms of California, we went to the head EH director for each state and asked for permission to talk to the local county health departments, and that was for Arizona as well as California. In Texas, we went to the head EH director, and we got permission to talk to the cities. In terms of what we did, we basically told the waterborne disease coordinators, so the EPI person, our contact person for waterborne disease in each state, that we were doing this, and said that we were contacting environmental health just so that they knew, since this was, I guess from our end, an EPI-related project, but we were using EH data. And then I guess 24 hours before the report went out, the waterborne disease coordinator in each state got a copy of the report. We did encourage our EH colleagues to provide the findings to them earlier, because each of our partners had a copy of the entire report early as well. But just to cross our T's and dot our I's, 24 hours ahead of time, we reached out to them. In terms of private pools, to know, none of the jurisdictions we worked with inspected private pools. And let's see, restaurants. Looking at Jeff Boynton's comment, restaurants have lettered, posted, ABC, et cetera, designate the type of observed sanitation based on many variables. Could aquatics facility also be graded with a clear and understandable post? Yes, we totally advocate for that. I will tell you, we did a national survey back in 2014. Most of the public has no idea public aquatic venues are inspected. And I think trying to introduce them to that concept and getting them, used to seeing a score, whether that's a number score or letter score, is a great idea, because I don't think they're going to adopt, including inspection scores into their swimming experiences until we make it easier for them and more knowledgeable. And basically the question I raised over and over again when talking to the media about this report was, when we go out to eat in a restaurant, we check the inspection score. There's no difference before we go out to a public pool. And it was something that resonated pretty well with the public. And from Heather.
Michele, I've been going back and forth as well on here.
Oh, okay, I'm sorry.
With Jeff. So no, I think you are caught up. So far, we're caught up right now. We got a couple other comments coming in as we speak, so we'll wait on that.
Okay.
Michele, I think there was also a clarification from Susie. She was, when she asked about the source of the report, she was referring to the illness reports in the background section, I believe.
Oh, okay. So the illness reports, they come from our state partners. So when there are reports of outbreaks, our state partners report those. If they're individual cases, like let's say there's a crypto outbreak that involves 50 people, there are 50 individual case reports that come to CDC, and there's also an outbreak report that comes to CDC.
And Michele, we got a question from Mary Clifton. If a pool or spa is located at a privately rented cabin/house, were those included in this as well? And I'll let you respond, and I also have a comment to that question.
To my knowledge, none of these jurisdictions regulate that. I know that's repeatedly come up as an issue in our outbreak reports where someone is renting their condo and they happen to have a hot tub there. And I know there's a couple states that have actually tried to get into to do some water testing of these aquatic venues, and they're just kind of falling through a hole, and they're not looked at, but they need to be because they have been involved in multiple outbreaks.
Yeah, I didn't have much to add to that. You covered that well. This is certainly a gap or a gray area. We actually had a nice discussion during our first listening post focus session at the NEHA conference where we spoke with a number of jurisdictions that are struggling with how to address these quasi-public/private pools where people rent these facilities. So it's something that certainly needs more conversation about how we can improve on that side.
Yeah, and I see that Susie has added a comment saying that illnesses are underreported, which I definitely think is true. And I think that the outbreaks, the hot tub and spa, Pseudomonas folliculitis outbreaks, are to some extent underreported. And I think some of it is coming from the fact that we know what it is, so we fix the situation, we clean up the hot tub and move on because we have so many competing responsibilities going on. I'm not sure that drop in spa-associated outbreaks, given what we're seeing in terms of disinfectant violations, is actually, I don't know how true that is. So I definitely think there's underreporting.
You have a question from Susan Wichman. Do you run into problems gathering data from hotels, motels, and apartment condos because they're not inspected?
No, so I think they are being inspected. It's just our local and state partners don't necessarily collect the data to indicate where they're inspected. So we'll get a report on a pool inspection. I have no idea if that pool is located in a hotel motel, if that pool is located at a water park or whatever. So that's something, that was one of the recommendations we made in terms of setting up a database, and that's something we included in the Model MAHC inspection form, was this idea of, collecting these data, because I think they are very key. I don't know. I think, our water parks, for the most part, tend to be run pretty well. Would be my guess, that they tend to have professionals that only do pool operation, whereas our hotel, motel, our apartment complex, you have someone who's responsible for the pool, but also 20 other things, whether it be the air conditioning, the landscaping, and everything else. And, it just becomes this one more thing to have to do and not something that someone can focus on. So we'd really like to see what those data and kind of get a sense of what's going on. But if I had to guess, I would think our water parks probably fare better than some of our other settings.
Okay, we got another question coming in.
So Mary's question is, will you be conducting additional studies in the future? If so, how could a state participate? So we hope to get these reports out every 2 years, or maybe every year. We don't know what that looks like right now. These were 2013 data. We already have 2014 and 15 data for the most part analyzed. We do want to do this in the long term. Right now, we're still planning. We don't know if we're going to stick with our 25 jurisdictions or expand on and outward from that. I think that the more pools we cover across the country, the better a snapshot we can take of operation and maintenance, but we'll see. I mean, if you have interest in participating in the future, maybe we should stay in touch and see how this all evolves.
I would also say, too, from our perspective, too, this is a dialogue with other state and local jurisdictions that may want to take this upon themselves. And I think there's a wealth of expertise here with Michele and team as they begin to sift through this data that might make life a little bit easier if the local jurisdiction wanted to analyze some of their own pool data.
I know when we presented these data to our EPI partners preliminarily in December, so it's basically attended mostly by our EPI state colleagues. New York City expressed a lot of interest, so this might be something they're exploring, and maybe they could present in the future and what their experience has been with it, how they've handled it in-house.
And then Scott Boren asked, have the states participating had any adoption of the MAHC, either wholly or partially? Let's see. So New Mexico is the first state to have widespread adoption of the MAHC, and we've had some minor uptake of the MAHC officially in a few of the states. But Michele, do you have anything to add to that?
To my knowledge, I think California's looked at some of the aspects of the MAHC. I don't know where they are, right? Is that right, Jason? You know.
Yeah, so I guess the short of it is that this is really considered a baseline prior to MAHC adoption. Now it's important that we were able to get this done to form that in baseline, because as parts of the MAHC get adopted, our tracking systems here will pick up that MAHC adoption, whether it's partial or complete, and specifically looking on some of those items that we think are most critical to reducing the risk of injury and illness. So that was really the point of getting this baseline report. So in the future, we should be able to pick up on and account for MAHC adoption as an interim metric for evaluation for the MAHC. And we are aware of quite a few jurisdictions that are in various stages of adoption. As Michele discussed earlier, adoption can take anywhere from 1 to 3 to 4 years from idea to conception. It's not something that occurs rapidly.
Or uniformly across the U.S.
Say what now?
It doesn't occur uniformly across the U.S. either necessarily.
Yeah, that's correct.
All right, it looks like we have just a couple more minutes for some final questions and comments. Looks like we've got one more coming in. All right, well, I don't see anybody else typing. We also have Michele's contact information up. But if you are not on Adobe Connect and you are just calling in, it'll be, if you would like to contact her via email, her email address is acz3@cdc.gov. All right, and then we just have one more quick announcement. For our next webinar, we'll be featuring, from the other side,
It's okay, Kelsey. It's the industry perspective from the Model Aquatic Health.
Sorry, I was at a loss for words.
No, that's okay. So
I could only think infrastructure.
Yeah, that's all right. No, it's the industry perspective. So we'll have multiple speakers. We're still lining them up at this point in time. But essentially, we're going to be focusing on the industry perspective for the Model Aquatic Health Code and the need for their desire for uniformity. So the other side of the coin in September. So we think it'll be an interesting webinar, and we encourage you all to mark your calendars. We'll get a save the date out here shortly for that September webinar.
All right. Thank you, Jason. With that, we will adjourn, and please be on the lookout for that next webinar invitation. Thank you all for joining.